Welcome. I'm Tim Showalter, Chief Medical Officer at Viz AI, and welcome to the Vizion Expert Series. This is a podcast where we speak with the visionaries who are shaping the future of healthcare AI. This is where deep healthcare insight meets real-world patient impact. We're talking with the experts who are not only innovating, but also implementing AI in ways that are transforming care delivery for both patients and providers. Today, I'm fortunate to be joined by Dr. Ugo Egolum, a program director of the Cardiovascular Disease Fellowship Program at Georgia Heart Institute in Northeast Georgia Medical Center, who's a board-certified cardiologist specializing in advanced heart failure, mechanical circulatory support, and cardiac transplantation. Dr. Egolum completed his medical degree at Howard University College of Medicine and his residency and dual fellowships at Vanderbilt University Medical Center. At Georgia Heart Institute, Dr. Egolum is helping lead advancements in heart failure and cardiac amyloidosis care, with the focus on improving how complex cardiovascular conditions are both identified and treated. We are especially excited to have him on today because of his involvement in the Viz AWARE trial and his perspective on how AI can support earlier diagnosis and better care coordination for patients. So Dr. Egolum, welcome to the Vizion Expert Series.
Thank you so much. Thanks for the invite, Tim. I'm happy to be here with the team and looking forward to a great discussion about this topic.
Well, it's great to have you, and I'm really excited for the conversation. I know you're right on the leading edge of all the topics we're going to cover today. I wanted to start at the foundation because I think that's where a lot of our listeners may not be as familiar with cardiac amyloidosis as they are with, say, like heart failure in general. Can you walk us through what amyloidosis is, what's actually happening within the heart, and why it matters clinically?
Excellent. That's a really great question. I think the term amyloidosis has been heard more often now, and it's sort of become a buzzword, if you will. But ultimately, amyloidosis in a nutshell is not one disease, but rather a group of diseases. So we have proteins in our body that have multiple different functions. And in their normal structure, they carry out their normal healthy function to keep us alive and doing well. However, in some patients, for a variety of reasons, these proteins fall apart and they form what we call amyloid fibrils. And these fibrils behave very differently. They deposit in organs in the body and cause damage. So for example, in cardiac amyloidosis, these protein pieces that are amyloid fibrils deposit in the heart and lead to what we call restrictive cardiomyopathy, heart failure, and worsening symptoms. Now, when we talk about amyloidosis, it's important to recognize there's many different forms. There's really two forms that affect the heart. One is what I describe as coming from the liver, related to TTR, and the other comes from the bone marrow, and that's what we call AL amyloidosis. Those are the two most common that affect the heart, but very important that both of these are distinguished. Ultimately, I think an important point to note is that this is a universally extremely symptomatic disease. It's systemic, and when not diagnosed or treated, patients die, unfortunately.
Well, thank you for that overview. I've recently learned about this topic, and it's really fascinating. It's something that I've heard from the oncology side, and then have learned a lot more from the cardiology side. When you think about the actual patient populations that you're seeing in clinic and in your practice, who is most at risk in general, and is this something that tends to show up at a certain stage of their care journey?
Excellent. Real great question. So from my perspective as a cardiologist, I generally see those patients that have the TTR cardiomyopathy. This is, again, the amyloidosis that come from a protein from the liver. Depending on what version of this amyloidosis the patient has, that oftentimes determines when they present. So some patients may have a genetic form of this disease that runs in the family. So some of those patients can present at a much younger age. However, some patients may have the version of disease, what we call the wild type, where it is not a genetic mutation, it doesn't run in the family. And those patients tend to present later in life, in their 60s, 70s, and 80s. So again, it just depends on what variant of TTR amyloidosis the patient has, and that determines what group, how they present. So really the whole gamut, young, old, and in between.
And for those of us who are not cardiac experts like myself, I'm curious, what are the main things you look for or one would expect from a patient when they present with cardiac amyloidosis?
Yeah, so the symptoms can be variable, but I think the main things we oftentimes see by the time we see the patient is they may be having heart failure symptoms. So shortness of breath, swelling, they're having fluid buildup and really low functional status and not able to do much. Some patients may manifest with heart rhythm issues, particularly atrial fibrillation, which is very common in this patient population. Aside from the cardiac manifestations, there's other things that may clue us in. Some patients may have neuropathy, so a lot of burning, nerve pain, and tingling sensation. And then other patients may manifest with things like carpal tunnel syndrome. So, for example, if we see carpal tunnel in both arms, usually we're very concerned about cardiac amyloidosis. Other aspects of heart problems they may have, some patients may have aortic stenosis, and that sometimes clues us in as to what symptoms they're having, and we look further to figure out what's going on with them. But a lot of times, ultimately, it's mostly heart failure that drive them to be evaluated by myself as a heart failure cardiologist.
Thanks. It seems like a complicated diagnostic process, and I can imagine that there can often be delays in general. And I'm aware that we've made real progress on the treatment side. So I know there are approved therapies that can meaningfully slow disease progression. So obviously it's important to get patients identified and get them access to therapy. But it seems like the diagnostic gap is still quite large. I'd love to hear your thoughts on how challenging is the diagnostic gap in terms of delays in diagnosis, and where does it come from?
Yeah, I think one way to show you an example of the diagnostic gap and how long patients wait is I'll give you an example of a patient of mine. This is a gentleman in his 50s, police officer here in the area where I practice. He was at the gym working out and he had a sudden cardiac arrest. However, luckily for him, there were bystanders who did CPR, and then eventually he was brought back and brought to the hospital for further evaluation. We evaluated him and ultimately we diagnosed him with cardiac amyloidosis. So now that's an extreme example, but it just shows that this gentleman probably had amyloidosis for a long time, but it wasn't picked up till he died suddenly, and then the ball got rolling. So that gentleman ultimately did well. We made a diagnosis. He had a variant form of the disease that runs in the family, so we had to screen his family. We got him on appropriate treatments. He's gotten better. He had neuropathy. He was treated for that and is back working. But I think really the ultimate reason why there's a delay is if you go back to the symptoms I described earlier, there's many patients that have that, right? As any clinician, we hear about shortness of breath, tiredness, fatigue all the time from many patients. So I think because this disease symptoms overlaps a lot with other diseases, that's a big part in the diagnostic delay. But I think, again, as we provide more education about this disease and people becoming more aware, we're honing on these red flag symptoms, things that don't quite fit the regular run-of-the-mill symptomatology that patients may have. And then that really prompts that extra diagnostic process, again, in the context that now we have so many treatment options, it really behooves us to push hard on that aspect of things.
Interesting. And what I'm hearing is that that story shows you how fortunate that patient was to be in an environment where people knew CPR. If he was perhaps had a cardiac arrest while hiking in a remote area, he and his family may not have been so fortunate. And so it just shows you that we're relying on chance so much. And I'm curious, do you think that means prevalence is much higher than we appreciate based on unrecognized diagnoses?
Yes, I think that's definitely something we're seeing in the field. Initially, there was a sense that this was a rare disease, but now that there's therapeutic options and we're able to screen for the disease much more easily with readily available imaging studies at most cardiology centers, we're finding the more you look for this disease, the more you find it. So I think in my view and many other experts in the field, to us, this is not a rare disease, and there's a lot of patients that are yet to be discovered.
Okay. Yeah, and it seems like we're hearing a lot more in general about cardiac amyloidosis, and there seems to be a real momentum building around it. You hear from industry, from clinical researchers, from health systems, and I'm sure a lot of this is being driven by technology. I'm curious, what are the main points that are driving this momentum we're seeing?
Yeah, I think probably the biggest one is the fact that we now have therapeutic options. I'll give you an example. I finished training at cardiology fellowship in 2017, and at the time I graduated, there was really no approved therapies for another year or so. So now in the last 10 years, 8, 9, 10 years or so, we have more therapeutic options that can actually treat patients. So previously, this was more of an academic exercise. You told a patient, hey, you've got cardiac amyloidosis, but we had no options. But now with multiple options being available, physicians are more inclined to look and try to find this disease so we can actually treat and take care of patients.
That's amazing. Yeah. So now that you have more tools, in a sense, I guess it becomes a more urgent issue, right? You got to
Yeah,
find those patients. It's almost an ethical imperative.
exactly.
I'm curious, what are the areas that you're most excited about in terms of new ways to diagnose patients earlier?
Yeah, so a couple of things. When we look in the context of AI, I mean, I think this is one of those tools that's going to really revolutionize how we take care of this group of patients. Again, the key here is earlier diagnosis, potentially at the point the patient is not yet symptomatic, right? So I gave the extreme example of my patient who died suddenly, but we want to figure this out before we get to that point. So there's a lot of data and work has gone into the AI space. So there's now available AI-enabled EKG screening, right? So we can look at patterns on the EKG that pick up possibility of amyloidosis. There's a technology available, just like Viz AI, where we can actually review echocardiograms using AI technology. And using pattern recognition, we can figure out that, hey, this person's echocardiogram looks like the possibility of cardiac amyloidosis. And further on, now being able with Viz AI to integrate the clinical context, the patient's labs, their past medical history, the echocardiogram. So we're now able to go sort of back and be able to put forward a picture of a patient that may be at risk for amyloidosis or may have the disease, but is yet not diagnosed. And you can imagine if we're able to apply this in a large health systems, review echoes, clinical data, we're going to be able to find a lot more of these patients before they become extremely symptomatic.
That's interesting. So I know you're on the forefront of this space, but also we're at this early stage in terms of broadening access to AI tools.
Mhm.
And I'm curious to hear your thoughts on how AI can make a difference at scale. Sort of, I can imagine there's the access issue of getting patient data run through the algorithm, but then there's also coordinating the downstream care. What do you think are the right strategies there that health system leaders should be thinking about?
So I think it's important for health system leaders to realize how burdensome this disease is for patients, right? When a patient has this disease, and oftentimes it's a good 3 to 5 year delay to diagnosis from the point of symptoms. These patients are not just sitting at home, right? They're extremely symptomatic. They may not be able to work. They're heavily use the health system. They're in and out of the hospital. And then the disease is highly burdensome and fatal. So I think within that context, one needs to realize, again, the burden on the patient, burden on the system, and figure out ways to move ahead of the stream. So again, identifying the patients when they're fairly asymptomatic is key. What this system allows us to do is to be able to screen patients that are already within the health system. And in doing that, we can identify patients at higher risk and then create workflows that we know we have appropriate staff and we can now target our resources to find those specific patients, screen them appropriately, and get them diagnosed. So in my view, it will be a very cost-effective way of doing it rather than waiting for the patient to become extremely sick. So I think that workflow process really changes the paradigm of how patients and physicians interact. So rather than wait until they're sick, we're actually proactively reaching out and say, hey, look, we're seeing signs or symptoms or things that says you could have this disease. Let us interact with you and figure out how we can make that diagnosis as early as possible and get you on treatment. In terms of workforce aspects of it, again, I think the big part there is ensuring that this fits into the workflow. I think the way we do things now, this fits perfectly well. It allows us to look at retrospective data and even data in the current era, and then being able to integrate that with appropriate staffing to appropriately look out for those patients. When I think of other disease states, we may look at things like diabetes, for example. When patients are in hospital uncontrolled diabetes, there's processes to identify them and direct resources. So again, the setup is not overly different than what we've done with some other disease states that we want to make a big difference for.
Well, it's really encouraging to hear that. And I just want to call attention to your response. What I love about it is that it's not only emphasizing what's on the leading edge of AI for disease detection, but you're thinking immediately about how this fits into clinical workflows and how we can really translate that into patient impact. Along those lines, I know that you are participating in the Viz AWARE clinical trial around cardiac amyloidosis. I wonder if you can comment about what you're most excited about with that work and what do you think the potential implications will be for the field?
Yeah, what I'm really excited about is, again, having this technology and applying it to this disease state, right? Being able to identify more patients and really being able to make a difference in the life of patients. That's number one. I think number two, be part of this, we're going to be part of a network of cardiologists who help to shape this technology, right? So our goal is really to apply it, ensure it does well, and make sure we make changes that need to be done. And then sort of be a background as to how this could be applied to other systems. So as we've learned and come up with the best practices, we will share this with others and increase that pool of folks that are looking for patients that have this disease process.
I think that captures it all. Like you've got, the patient impact, deep involvement with cardiologists, and then engagement of health systems overall. And it's generating evidence, obviously. So that to me starts to get into like the building trust equation and how that works to really make a change that's meaningful within the health system. And I know that cardiologists are among the most rigorous specialists in terms of evidence-based practice for large clinical trials, a real embrace of real world data, and so it's a high bar, obviously, to move the needle. And I'm curious what level of validation you think is required for AI tools before cardiologists would trust them, and before you'd start to recommend them to a colleague.
Yeah, no, another great question. I mean, I think what we can lean off of is a framework of how we've done other things, right? So how did aspirin become standard of care for management of CAD? Well, we had randomized studies that looked at data. We have data prospective matter. We have retrospective data. We looked at sensitivity, specificity, and over time, that data proved itself to be trustworthy and verifiable. So I think it's going to be the same with AI. As we do these studies and analysis, we make sure they're very rigorous. We adhere to strict protocols and looking carefully at the data and evidence we find. Does this make a difference, and how does this impact patient care? I think once you can demonstrate that in a standardized, systematic way, I don't think most of us as cardiologists will have a problem adopting the technology.
Great. Yeah, and I'm hearing an emphasis on affecting patient care in a positive way, which hits on the clinical utility much more than what we think about in clinical validation for showing that an algorithm can identify a patient with a certain performance criteria. It's more about like actually impacting patient care, which I agree is the most important. I did want to touch on this subject related to the evidence and trust, how you're thinking about this as a fellowship program director, because in addition to being on the leading edge for healthcare AI and cardiology, you're also training the future workforce. And so I'm curious for how you're thinking about this in terms of your training program.
Correct. And I think that's a really exciting aspect of this, right? I mean, as I look towards the future, I think in the next 5 to 10 years, cardiology workflows are going to change dramatically. We've already seen this as a shift from a lot of inpatient medicine, and now we're doing a lot of things outpatient. So in that context, I think it's important that cardiology fellows, who are the future of cardiology, are able to have access to this technology, learn about it, how do we implement it, learn the workflows, and be able to learn this in a context where they're supervised so they can be comfortable, and then in the future be able to apply it as they go to independent practice. So I think that's really exciting. And of course, when you have cardiology fellows, they're motivated, they're excited. So the impact they'll have on shaping this technology will be an important aspect as well. But definitely, it's a big part of preparing our future workforce.
That's great. And more broadly, outside of cardiac amyloidosis, and when you think like maybe within heart failure in general, how do you think that shows up for like what can current fellows expect? What is their current what are their current training needs, and what can they expect when they graduate and enter independent practice?
Yeah, so quite a few things. I think in the current context, for the most part, we still work on the patient gets sick, they come to see us model, right? But now the fellows are being exposed to a different way of caring for patients, that more proactive way where we move upstream and identify patients, hopefully before they're symptomatic. So that's one aspect. I think number two, the more of these patients we identify, the more exposure our fellows have to taking care of these patients, seeing what's involved in their care, prescribing appropriate medicines, and following them closely. So now we're building a much larger group of folks who as they train, taking care of amyloidosis is part and parcel of what they do on a daily basis. I don't think so far we've had a generation of cardiologists that have been trained in that context. So you can imagine the leverage that our future workforce will be, if we do this successfully.
Great. Related to that, at Viz, we've been really focused on cardiac amyloidosis as well as hypertrophic cardiomyopathy over the last couple of years. And I'm curious, for both of those conditions, we now have AI-based screening tools where we can collect information and act on it from throughout the health system. So you've got an EKG or an echo that's been performed elsewhere. And so it does create this opportunity, as you alluded to, of being more proactive and potentially finding patients in the health system who aren't in your clinic yet, but who you can act on. And I'm curious, as a leader at your health system, how that impacts the way you relate to your colleagues more broadly outside of cardiology. What do you think are the opportunities there?
I think the opportunities are immense. I think as cardiology is one of the specialties taking the lead on this, once we implement and do this successfully, then it kind of emboldens others. Like, cardiologists have done it for this disease state. Why can't we apply this more broadly to other disease states? So I think that's one context. The other part is, I think with AI technology, we could potentially change the landscape of disease processes. As you're aware, outcomes for heart failure patients, amyloid, and so on, generally still not overall great, right? So we still have some opportunities. A lot of improvements have been made, but we know readmission rates to the hospital is still pretty high for heart failure. We know the mortality rate is still pretty high for a lot of patients with advanced heart failure who are not identified. So really, I think this technology could have us change the prognosis of many of these diseases, right? So imagine we identify this early, we start therapy, and patients never worsen to the point where they have to be in the hospital and stuff. So some of these disease entities that we treat in the hospital now, when they worsen, may end up purely being outpatient diseases, right? Maybe we take someone's prognosis of, having a 90% mortality of 5 years to the 0% mortality, right? So now the patient is living a much healthier life and the disease process is completely modified. I think that's really where the huge opportunity is as we move forward with this technology.
That's really encouraging because it becomes basically like modifying the overall disease course and turning a situation into an opportunity for just converting it into a chronic manageable illness. I'm also thinking from the patient perspective, the engagement with the health system can almost be where you expect that there are leaders and innovators like you who are potentially have tools to monitor their information across the health system so that if there is a condition, they can find an earlier diagnosis. So it makes potentially the health systems one step closer to a proactive care model, which is pretty encouraging.
Oh, definitely. And I think that ties in well as we look at, compensation models that are changing now for hospitals, right? We talk about value-based care, right? This is the perfect value proposition that, hey, we can find a more cost-effective ways of care for patients. Patients do better, they feel better, they're less sick. So it's a win-win for everyone who's involved in this whole aspect, I think. And I think the other part too is AI, I believe, will be a level playing field. I think for a long time, the cure of amyloidosis was sort of restricted to the ivory towers, the large university centers. But again, by applying this, particularly in a setting like mine, where it's a large community hospital, and this can be deployed in either type of settings, private clinic, a hospital setting, a large center, then really all across the board, whether you're a small rural hospital, one in a large city, this levels the playing field and really increases patient access, right? So now I know a lot of patients have to travel 2-3 hours to find an amyloidosis doctor, right? So this sort of will level that playing field where you can bring cure closer to home for the patients and overall improve their interaction with the healthcare system.
That's really exciting. Well, I know we're coming up to the end of our time together, and I wanted to close on a future-looking question. And we've covered some of this, but I'm curious to hear your thoughts as we point the conversation really directly to cardiac amyloidosis and heart failure in general. Usually we think about what's the vision of healthcare in 10 years or 20 years, but of course with AI and the speed at which we're moving, it's probably better to think about 1, 3, or 5 years. And as you look to the future, What's the message for patients and their families who are affected by cardiac amyloidosis and heart failure? Like what does the future look like with AI?
Yeah, I would say the future looks bright. Patients now can look forward to being diagnosed much more early in the disease process. Patients can look forward to having appropriate therapeutic options deployed and be treated appropriately. Patients no longer have to wait 3 to 5 years, recurrent symptoms, multiple doctor visits to get a diagnosis. And I think there's implications for future generations, right? So when we figure out someone has a variant form of this amyloidosis that runs in the family, there's a bigger implication that happens for the rest of the family because now they're made aware of the disease state and they understand that, they have to screen and appropriately cared for. But ultimately, what I think again with AI is as we deploy these tools, it really opens up a multitude of options. So I can think of things like clinical research, right? So if you're able to identify more patients, there's more opportunities to engage patients in clinical trials. So not only are we impacting and implementing today's care, but it's going to allow us to look at future therapeutic options that make enrollment into clinical trials a lot easier because we're finding patients and appropriately treating them accordingly and exposing them to those therapeutic options. So those are the key things I think will be the impact in the next several years.
Well, Dr. Egolum, thank you. It's an exciting near-term future that's right around the corner. And I really appreciate you joining us and for sharing your perspective and look ahead. I think this is a really important conversation. It's the kind that I think will resonate with really anyone who's working at the intersection of AI and cardiology.
Excellent. Thank you so much for having me.
Well, thank you. And thanks to our listeners. Thank you for tuning in to the Vizion Expert Series. Join us for the next episode as we continue to explore how AI is expanding access to life-saving care and transforming the way patients are treated.